privilege of running the NCH um, Center of Excellence at UCLA. And in doing so, have had the wonderful opportunity to work with and mentor Dejanay, as well as lots of other wonderful trainees. So I'm excited to be here with all of you today. Excited that people are interested in pursuing maternal and child health because, well, I'm very biased, clearly, but I think it's the most important field. So I'm glad that you are all here supporting its future.
Perfect. Thank you so, so much. So a little bit about what we hope to bring you today in terms of content. We are going to go over the multi-hyphenate approach, which Dr. Gragnani uses pretty much in her everyday work, like she said, to bridge those clinical health roots with a little bit of research as well. And we're going to go over her transition from clinical, where she was previously a pediatrician, and an infectious disease doctor, and moving into research now and working with UCLA as well. Also, we're going to talk about prescribing beyond the pharmacy, so a little bit of a different approach outside the typical way for prescriptions to be provided. And then we're going to finish off with the centering pregnancy model as well. We do have the Q&A feature available for you guys. So if you're on your phone or your laptop, you should be able to see the three dot option at the bottom. And if you click Q&A, you have the ability to submit anonymous or questions attached to your name. So we'll do an open Q&A at the end as well. Okay.
Okay, so we wanted to start off with this kind of multi-hyphenate approach and do an interactive poll. So, okay, we wanted to ask if you had to pick a side today, would you choose clinical or research? And we'll launch it right here. Okay, let me know if you all can see that, and then if you can join the poll, and then we'll end poll when we see that everybody is kind of submitted. Okay, we're at about half participants right now. So if everybody could join this poll, and then we'll have a discussion. Okay, we're looking about 40 to 60 clinical to research. That's where we're at right now.
There we go.
Okay. Okay, one-third to two-thirds clinical to research.
Okay, there you go.
Yeah. Anybody else want to join before we close out?
I can't even vote,
It's
but I vote
I
clinical.
voted.
I know, I was like, Amaya and myself cannot vote. We're impartial parties. Okay, so we're looking at about one-third clinical and two-thirds research. Does anybody want to talk about why they chose what they chose? Anybody in clinical so far? Anybody who chose clinical? Why'd you choose clinical versus research? Yes, Naya?
I'm actually not even in either one of them right now, so that's funny. But I do want to be an OBGYN, so that's why I chose clinical. I just prefer to talk to people. I've done research. I think it's important, but it
Mm.
gets boring. Like, I don't know. I get bored sometimes. And I just want to talk all day to people and make them feel like seen and cared for. So, but I do think
Mm.
research is important for sure. Honestly, I would, they both equal, but I don't know. I think research is like 1% more important, but I'd rather be on the clinical side.
That's awesome. Thank you for that. Okay, does somebody want to talk about why they chose research instead of clinical?
I can share.
Mhm.
I had a internship with Highland Hospital here in Oakland. And I was just like exposed to different parts, and I was just like, oh, I don't think this is for me. And so yeah, that was my experience. But I would have in another life, OBGYN would have been my path.
Okay, so the clinical experience was maybe a little too like intense for you, so you were like, okay, research may be a better path. Okay, okay, fair. Thank you all for sharing. Let's see. Okay, there we go. Okay, so Dr. Gragnani, can you, in this moment, describe I know you gave some of the places that you've been affiliated with. Can you describe your professional journey and like kind of your clinical background, and then how did you get involved in research? So bridging that gap in the first place.
Yeah, absolutely. So I guess to provide a little bit of context, I'll go like a little far back. So I come from a farm family in a rural part of Central California, and pretty much everyone in my family farms. So that was sort of the context in which I was raised, in the sense that I didn't really have any understanding of what sorts of jobs and things were out there, or fields of work there were outside of agriculture. And then sort of like the standard, I think, what kids think of when they think of jobs, like teacher, nurse, doctor, police officer, astronaut, like the usual ones I feel like that come up. And my parents didn't go to college. So I think growing up, I sort of understood that I really loved science. I loved two things. I really loved science and understanding how things worked, and solving problems. And I also really loved working with people. Like, I loved listening to people's stories and forming connections with people. And so when I went to college, I sort of thought, oh, I think medicine is where I want to be, because that's actually a place where you can kind of bridge both of those loves, in the sense that you have to learn a lot about physiology and how the human body works, and how it interacts with other things that make it not work the way that it's sort of designed to, that can make it sick, or et cetera, et cetera. But you also get to really talk to people every day and learn from them, hear their stories, understand where they're coming from, and how that influences their health, and how you can sort of navigate it together to try and support them in the best way possible. So I went into undergrad thinking I was going to be a pre-med, and then sort of waffled back and forth between nursing and medicine, and ultimately decided to go the medicine route. After having a conversation with one of my TAs at my job at the time, I worked at a coffee shop as a barista, and she came in, and I think ultimately I decided to go the medicine route because I wanted to sort of be have more of a leadership role in my patient's care, in the sense of knowing my personality, understanding that if I was in a position where I felt like someone was getting suboptimal care, or I was like sort of disagreeing with the course of care, I didn't want to have to be in a position where I couldn't, I wasn't in a position to sort of change that. So I ultimately decided on med school. And really, when I went to med school in Chicago, at Northwestern, just really focused hard and enjoyed all my rotations. I was pretty sure I wanted to be a pediatrician because I really loved kids. And I thought that kids were a very incredible lever to actually motivate whole family units around health, in a way that oftentimes as adults we maybe aren't able to motivate ourselves around our own health, in terms of our health habits, or things that we're doing at home to either foster health, or maybe not foster health as much. And so I really loved that part about pediatrics. That being said, people who don't want to do pediatrics hate that part about pediatrics. So it's like very, you either love it or you hate it. You either love taking care of a whole family, or you hate it and you're like, you just want to take care of like the adult in front of me. It's like, so I will say anecdotally, I get that sort of sense. And definitely if you are working with kids, you have to be prepared to work with caregivers and families, because that just comes with the territory. So I ultimately decided I wanted to do pediatrics. I toyed around with the idea of doing ICU care or surgery because I like using my hands. But I didn't feel there were two things that I was sort of, since you're all, I think, navigating career paths and priorities and all of that. So, as like a tiny soapbox moment, I encourage you to also think about things outside of your work that you want to prioritize if there are things outside of your work that you want to prioritize. Everybody is different. There's no right or wrong. It's just sort of whatever you want. For me, I knew I wanted to have kids and I wanted to be a bit more present when I was having my kids. So I decided not to do a surgical residency because those can be like anywhere from 5 to 7 years after you graduate from medical school. And there's tons of great surgeons who have kids and they're awesome parents. But just for me, knowing how much I wanted to be flexible, I ended up just deciding to pursue more of like a primary care training. So I did my primary care, my pediatrics training at UCLA, and I really enjoyed it. But towards the end, felt a little dissatisfied. I don't know if it's the right word, but I was struggling with feeling like, especially for my Medi-Cal patients, those of you who aren't from California, Medi-Cal is just what we call our Medicaid program. So for our Medi-Cal patients who I was seeing a lot in my pediatrics continuity clinic as for like their well child care, a lot of the issues that families were facing had to do with social and structural determinants. And as a pediatrician, it wasn't I didn't have the capacity and I wasn't sort of in a position outside of like trying to identify community-based resources to really help them navigate that. And I was frustrated because, in adults, we sort of identify things and problems and we're in a different place physiologically. And so the impact of all of these things in childhood starts to really come to fruition in health and adulthood. And I was frustrated because I could see that a lot of these kids were at higher risk for having poor health outcomes as adults, but we weren't really doing anything per se in the healthcare system now because there wasn't, from a medical standpoint, right, like anything wrong with them in the sense of they weren't hypertensive or they didn't have diabetes or right, like all of these things that we get as adults that we know are sort of chronic and life course illnesses. So then I was like, oh, I think this is public health because I had never really heard about public health before. And then I was like, oh, well, I guess maybe that's kind of what I want to do. So I did a preventive medicine fellowship at UCLA, and it's a really interesting field that combines public health training with population health interventions and sort of rethinking clinical care systems and their role. So the focus of preventive medicine is upstream, and it's also very much on population health. It's about caring for populations. And that's where I first started getting into health policy and management, which is what my MPH was in, but also started getting a taste of more research. My first project for my thesis was a park prescription program that we were working on with LA County Department of Parks and Recreation and the Department of Public Health. And it was really exciting for me because I sort of felt for the first time like, oh, I have found a space where I'm using my understanding of the healthcare system, what it is like to navigate it, sort of what people are dealing with from a patient population perspective in the areas of LA that I had been working in. But I'm also now working to try and figure out ways to bridge them to resources in their community that are exceptionally helpful. And working with community partners, which I also really loved, because I consider community partners healthcare providers, not in the same sense that they have like a medical license or nursing license. Like that's a very specific kind of healthcare provider. But there's tons of like community organizations and nonprofits that are, if you think about it, they're healthcare providers, right? Like, so that's when I first started getting a real taste for research, and I started working in the MCH Center of Excellence at UCLA. I started teaching in the public health school after I finished my fellowship, and had a lot of opportunity to explore more opportunities for community partnered research and interventions. And so I don't want to ramble too much. So I'll give a few examples and I'll pause and y'all can let me know where you want me to go. But so some of that has included, I talked a little bit about my parks-based work, which I do with my colleague, Dr. Priyanka Fernandez, and that's sort of evolved and taken on different iterations with our parks and recreation partners. We've done a youth-facing program for the last 5 years that provides a lot of health education that we've been trying to evaluate. We are doing a community partnered evaluation of 511 Hoops, which is a nonprofit here in LA that provides basketball, bowling, pickleball, STEM, and arts-based uh, events for autistic and neurodiverse youth and like transition-aged youth. Um, and I've done a lot of birth equity work with my sort of mentors and partners at Charles Drew University's Black Maternal Health Center of Excellence. So we've done a lot of shared like internship work. We did a series of focus groups with Black moms at UCLA to explore their experiences in healthcare and to inform improvements from a quality improvement standpoint at the UCLA health system. And that's branched out into now I've been helping to support Centering Pregnancies launch at UCLA under Dr. Lisa Nicholas and Maya Zapata and Ketchy Brody. Those are the OBs and midwives leading the initiative. And we're getting ready to evaluate that. Dejanay is helping with that, and we're so lucky to have her on board. So you can see it's sort of like gone haywire, to be honest with you. And I'm still navigating it on my own. But that has been a little bit of my transition from clinical to research. And my preventive medicine training is interesting in the sense that it allows me to be a little bit flexible in being present in sort of both of those spaces still. So I still do like population health and quality improvement work from a health systems perspective. And I use my clinical training for that. And then like during COVID-19, I used my training as a pediatrician. I was on the COVID-19, the multi-system inflammatory syndrome in children review task force for 3 years. I was reviewing all the case studies with a team of people there. So I still use it. I just not seeing patients one-on-one anymore. So it's been sort of an interesting and windy journey. It was not planned that way, by the way. Just if that makes anybody feel better, it was not planned that way. My dog's eating the remote control. I'm just gonna walk my computer over. Dejanay is probably my dog is very naughty and she's probably already heard me in meetings talk about my dog eating stuff. So don't mind me. I'm still here.
No, we're like that's thank you so much for that, for like taking us through the journey, right? Through school and like getting to med school and then coming into like the research side of things. That was really helpful. Thank you.
Yeah, of course.
Okay, now we have one more poll that we want to kind of give to the audience. And so I'm going to launch in a second, but we're going to ask which of these clinical issues do you think that this is the hardest to solve with research alone? And then Dr. Gragnani, we'd love kind of your input on maybe some of these issues and how we can solve issues with research versus with like clinical work.
Yeah.
Okay, here we go. Okay, everybody, let me know if you can see this poll. Okay, perfect.
Ooh.
Okay, cool. We've got about 8 out of 10 so far because I know, again, Amaya and I impartial.
I actually joined on my phone so I could vote.
Oh, yeah. Okay. Okay, any others before I'll like publish this poll? Okay. Okay, can we all see the results? Okay, great. So we've got about 25% are saying Alzheimer's, about 50% are saying diabetes, and about 25% are saying sickle cell anemia. Very interesting. Nobody is choosing cancer. And so we'd love to hear, whatever you've chosen, whoever has chosen Alzheimer's, if you could tell us why you feel like that might be the hardest to solve by research alone, we'd love to hear from you.
Okay, I'll go. So I chose
Okay.
Alzheimer's because I feel like there are so many no experience with Alzheimer's is ever going to be the same for multiple people. So I think it's difficult to solve just by research when every clinical aspect is so individual to each patient. And I also think that any neurological, I guess, disease or condition is just naturally requiring more hands-on, like studies and clinical trials and things of that nature versus other things that might be on here.
Yeah, absolutely. Mia, do you want to talk a little bit more about what you said?
Yeah, I totally can. Coming from a public health and a social work background, I feel like that's
Mhm.
something that you can kind of see like just different lifestyles. It may be more likely for somebody to get Alzheimer's than another person. And that's just kind of where my thought process went.
Thank you for that. Does anybody who chose diabetes want to kind of tell us why you feel like that may be the hardest to solve by research alone?
I could share. I chose diabetes. Um, I chose diabetes because I feel like since it's a like chronic metabolic condition, it does kind of also depend on like lifestyle circumstances as well. So that's why I thought um, maybe like having in clinic like conversations and how you would handle like certain like patients in clinic kind of also matters as well as like the research behind what sort of lifestyle sources or what causes diabetes.
Mhm. Absolutely. Thank you. Anybody else? Because I know we got about half that chose diabetes. So we'd love to hear maybe one more person that chose diabetes.
In the chat, Kendi said she agrees with what Mia said, because every community is unique and they all have different cultures and ways to
Mhm.
approach nutrition versus there being one universal method. So that's, yeah.
I think that's very interesting. Okay, somebody who chose sickle cell anemia. Why is that the hardest to solve by research alone? Yep, Naya.
This was a really hard question. I was really struggling with this, but um I think I went with sickle cell and also I'm not the most well versed in any of these topics, honestly, except probably
Mhm.
diabetes because it runs in my family. And I guess a little Alzheimer's because my grandmother had dementia, but I chose sickle cell because that was the only one that's not really caused by social determinants of health. So it's kind of like you just kind of inherit it and you're born with it. And that's why I said it's the hard, like you literally do need that clinical help. You have like from what my understanding is when people have like they are always have to be admitted into the hospital. They need like around the clock care. So you just couldn't solve that research versus diabetes like that the nutrition I understand like it's hard to try to convince people of a culture that they need to eat differently, but
Hmm.
technically the research is kind of there to kind of say the amount of sugar you're eating is not really helping you in your situation. And then they have a lot of ties to Alzheimer's, which I heard to your point, Maya, like that kind of is sporadic in that area. But I do think there are like smoking, I think was is something that you hear a lot about, just like how you can do better with your brain. So I just thought sickle cell was probably the hardest because I mean, you just inherit it and you have to get that clinical care.
Very fair. And you have to have very kind of targeted research, right? For sickle cell
Yeah.
anemia, right? Yeah. So I was even thinking, Dr. Gragnani, like, are there any like either any of these or any health issues, conditions you've seen that you've maybe focused more within clinical work versus research, or,
Yeah. I think I mean, I think this is a very excellent question. I'm not sure that I don't have the answer. I can tell you, I guess, sort
Yeah.
of what I'm thinking about it. And I like the examples that you and Amaya chose to sort of pull the audience with. I think they're sort of they're all pressing issues in the sense of morbidity and mortality, and particularly when you take into consideration equities in healthcare access, as well as disparities in outcomes. It's really I feel like becomes, when I think about clinical and research, it sometimes feels a little bit like a chicken egg situation, in the sense that, to everyone's point who has contributed to the conversation, thank you all for sharing your great thoughts. Right, you really need the clinical piece to understand what patients are experiencing, what is keeping them from accessing care, what is acceptable to patients in terms of care, which is also really critical, and sometimes, depending on the type of research, is not necessarily the focus of the research, right? Like, you could have a researcher come up with some novel, I don't know, medication that helps improve symptoms of some specific disease by 50%, but there's a X risk of fill in the blank, something that people may not be willing to take on, right? And you have to sort of be able then to navigate and understand with clinicians, and also be working with clinicians when researchers are rolling out new medications or vaccines, right? There's this really integral web of conversation between clinicians and researchers to understand, how is this rolling out in real time? Are people experiencing things that we didn't sort of anticipate they were going to experience based off of what we knew going in, and what research we had done so far? I think Jennifer's bringing up a really critical point for sickle cell in terms of transition-based care. And they're working on this actually at UCLA. Some of my colleagues, they started a UCLA Sickle Cell Center of Excellence in transition-based care for sickle cell, also for kids who have cancer. Can be really complex. Kids who have a diagnosis of autism, it's also very complicated, oftentimes transitioning their care. It's very interesting. I don't know that I can really tease them apart. I see everybody sort of as one big team. I think good researchers talk with clinicians to understand what they're seeing and experiencing, and get insight from on the ground, like, what is the need? Ideally, you're talking to patients themselves. That's not always possible all the time in real time, but clinicians usually can have a sense of need and acceptability and things like that. Because otherwise it can be pretty siloed, I think, from a research perspective, to just be thinking about a problem from a lab, sort of like a lab-based or like perfect design sort of perspective. Now, that being said, there's all different types of research too, right? Like, you can do your bench science, like pharmacokinetics, or you could do engineering research and design biomedical devices, or you could do more like behavioral health research, right? And then you're actually really working with communities and coming up with ideas for programs and evaluating them. So there's all different kinds of research too, which is interesting. But I think the tricky part is, like Amaya was saying, with Alzheimer's, but it's true for sickle cell, it's true for diabetes, and it's true for cancer. It's like every patient is so different that you see. And they experience it differently, and their family experiences it differently. And so you need everybody to be on the same team, I think, when you're working towards these big problems, to really tackle them well.
Thank you for that. And just finally, before we kind of move on from this particular area, we were wondering how, I know you said you don't really see individual patients that much anymore, right?
Yeah.
But how is your work within pediatric offices, but also within the DCFS hub, like fueled your current like UCLA research?
Yeah, so I think in terms of my current research, I think in terms of the DCFS hub, so working, and for those who are outside of California, or even outside of LA, we have a hub clinical system here in LA County. And there are 6 hub sites where pediatricians and additional staff who are trained in caring for children and youth who may have been neglected or abused in some way, who are coming into contact with their families with the Department of Children and Family Services and or law enforcement. They come into care, and they come into care to receive what's called an intake exam, which is to make sure that they're healthy and there's no acute medical problems, to keep them from being placed in foster care. You may also have to do abuse exams, and then that is where they could receive their well child care while they're in foster placement. And so I think that was a very heavy and hard sort of space to work in. I think what I took away from that experience, one, is that it was not a space that I could have a career in. It was very hard for me, I think, emotionally, to work in the DCFS system, and hear what these young people had experienced, sort of day in and day out. And so I didn't have the constitution personally to do it as a career. And I'm very grateful for the people who do. One thing that really struck me was the fragmentation of healthcare that kids in the foster system get, particularly because they might be going from sort of placement to placement. Just because they get placed in one foster home or with a foster caregiver doesn't mean that's where they sort of stay. And so it's very hard to coordinate their care as a pediatrician because they don't really have a consistent source of healthcare. And so that, to me, I did like a QI project when I was working there about just standardizing documentation of their asthma action plans, which sounds very basic, but a lot of these kids were super high risk for asthma. And had asthma, and unfortunately kids still die from asthma, and asthma's no one should die from asthma. We have the medications to manage it, right? And so that doesn't mean it doesn't happen. And so to me, it was just sort of like what can we do to make sure, at minimum, for these kids with asthma who are having asthma attacks and things, whenever they're moving around from place to place, their asthma action plan needs to go with them, right? Like the new foster parent should have it, and the next time they go to a pediatrician, that pediatrician should have it, and blah, blah, blah. So for me, what I took away from that experience, from a systems perspective, was trying to think better about sources of fragmentation in care, and then sort of thinking creatively about how to bridge communication gaps in the healthcare system, which y'all know are like, there's just so many in the United States, especially because we don't have one EMR. And so I took that and have incorporated that into some of the work we've been doing, which is not totally related, but we're trying to build a partnership between UCLA's OB-GYN department and then the Charles Drew University Black Maternal Health Center of Excellence. And some background, the purpose of this project is actually to create a longitudinal relationship that links a clinical healthcare provider, so that's UCLA, the academic sort of medical system, to a community healthcare provider, which is the Black Maternal Health Center of Excellence, that provides a lot of community-based resources and access to supportive care like physical therapy and lactation and support groups and mental health. Things that are hard for people to navigate and access just within sort of traditional medical care models. And what we're trying to do is bridge that gap between us working together and create a way for us to communicate in real time so that we can share care of patients, so that patients aren't, which oftentimes, right, is seeing one person and then seeing another person, and then, the first person's like, okay, what did they tell you here, or what did that person do for you? And then that person goes, okay, what did the other person tell you and do for you? And then we're sort of making the patients, we're putting them in a position that they shouldn't have to be in, which is telling us what everyone else has been telling them to do and doing it sort of on the fly. So kind of, it doesn't seem related, but in my head, it is related in the sense of thinking about how do we bridge together these systems in ways that are more meaningful, and how do we fix the communication problems that we often face, because I think that in and of itself oftentimes contributes to suboptimal care, right? Just our lack of clear communication across channels. So that's like one clear example that sort of comes to mind.
Definitely. Thank you. Thank you for that. I was just saying briefly in the chat too. So thinking about continuing care,
Yeah.
seeing this through line of care, right, for children going into the foster care system, but also maybe even following them through their like foster families and the healthcare system around them. So that's really important. Thank you for
Yeah.
that.
Okay, perfect. So we want to move on a little bit more to the research perspective that you hold now. On the next slide, we'll discuss a little bit more about maternal health. But in terms of pediatric and child and youth health, what are some ways that you incorporated lifestyle medicine when you were practicing, or even now, within your research?
Yeah. So, and for those of you who are a little bit less familiar with lifestyle medicine, let me put a link in the chat if you're interested in exploring it more. As just a topic of interest. So, lifestyle medicine is essentially like a very upstream approach to thinking about health in general, but then also in terms of thinking about mitigating and alleviating chronic disease. So, the American College of Lifestyle Medicine is its own sort of organizational entity, and you can get certification in being like a lifestyle medicine provider as a physician. And the tenets here are really to focus on sort of six, what they call like the six pillars of health. And so those six pillars are optimal nutrition, so eating more whole foods, eating less processed foods, and predominantly eating plant-based per their recommendations and per research. Physical activity, right? So moving every day and making sure you're targeting strength and flexibility, and cardiovascular activities. Stress management, sleeping well, so getting high quality sleep, avoiding risky substance use, and then social connectedness. And they've actually done a lot of research in terms of one, helping to prevent, but two, also helping to reverse chronic disease progression, particularly cardiovascular disease and diabetes, for people who are able to be supported and access these health promoting opportunities. And for those of you, I'll put this in, and then I'll actually talk about my work. Sorry, but for those of you who are really interested in this space, there's a lot of this work was sort of built on the Blue Zones research project, which was done by a group of individuals. And so the Blue Zones are really interesting. I just like, if you're sick of studying or reading about whatever it is your professors are telling you to do, check out the Blue Zones because they're very interesting. So a group of researchers decided to go to areas in the world where they had the highest number of individuals who were living, I want to say it was like to 100. And they found these six sort of areas in the world. One's Loma Linda, which is in like near Riverside in California, Sardinia, Italy. There's, I think, Greece, Cyprus, Greece. And then there's, let me think what the other ones are. Costa Rica, and there's one in Asia, and I can't remember its exact placement. Anyway, you'll read about it maybe, or you won't. You'll just say Blue Zones in a conversation. It'll be great party conversation starter. But that being said, so we recognize, like, if you think about it, right, what I just said doesn't sound very doctory. Like, I don't know how much like a doctor needs to be talking to people about this, right? I mean, it's helpful, right? As doctors, we should be talking to patients about this. The problem is, realistically, there's not very much time and space within annual wellness exams to have like a detailed conversation about like your sleep quality. If I have like 8 to 12 minutes with you as a pediatrician, I have all sorts of things I have to go through. And yes, I ask about like eating, like what are you eating, how much are you sleeping, et cetera, et cetera. But I also have to do your full exam. We have to talk about school. Are you wearing your seatbelt, your bike helmet? Are you riding an e-bike? Like, I have so many things I'm supposed to cover. And so there's not a lot of time and space to have meaningful conversation about this. And so my colleague Priyanka and I would try to create that space in my clinic to have these conversations. To my own demise, it was because then I would run very late in clinic, which is also frowned upon. So when I was working with my colleague Priyanka, who's also a pediatrician and preventive medicine trained, we've been trying to think about how do we sort of bring this concept, right? These ideas and this knowledge and space for conversation about how do I do this where I live, right? Like in the space that I live in, how do I do this? Why don't we try to bring that out into community? And so that was sort of where we started with our parks-based program. And so a lot of our work has focused on how do we create a community-based, essentially like lifestyle medicine curriculum that we deliver in parks to reach community members. And then is that like something people are engaged in? Are they interested in it? What works and what doesn't? So a lot of research questions sort of have spawned from there in terms of what engages people and what doesn't. What barriers do people have in accessing that? Versus, not accessing it. And is it because they can't access it? Is it because they don't want to access it? Right. And then from a quality improvement perspective, or if you're into implementation science, which is how do we take something here and then roll it out somewhere else? Or like, what are the parts that you take to make it work? In another sort of setting, we've done a lot of work with community-based tailoring of curriculum. So sort of individualizing curriculum based on different neighborhoods that we're in. And we've done that in various sorts of ways. And that is, there's lots of people doing this, not just us. There's lots of people doing sort of like a riff on it. I think we're doing it in park-based spaces, which is, I think, sort of unique to us in the sense that we're doing it in county parks. And now we're doing it in pocket parks with a nonprofit partner. And we are not tied to clinical systems. And we did that specifically, like we tell people about our program who are clinicians, and if they refer patients, great. But we actually specifically decided not to create a clinical, reliance on a clinical referral process, because we wanted to just go out into community spaces where community members could come. And we work in communities where we know people are underinsured or even uninsured. So we didn't want to have to rely on the medical system for them to hear about or get access to the programming. And it's been very messy, to be quite frank with you. No other way to put it. But great. But, community-based work is messy. And you have to be flexible, and there's a lot of adaptation, but you are also constantly learning, which is really great.
Yes, thank you so much for that. I was going to say, I definitely think an a barrier, I guess, for preventive and lifestyle medicine to kind of being a forefront to care is just patients having limited access, whether that's like transportation or not having insurance that will cover so many different services. So if anyone else wanted to jump in on the discussion or share anything in relation to what Dr. Gragnani just said, that would also be great. But no, that's actually very cool. I was thinking, I was reading through the, reading through the lifestyle, and I was like, this is kind of like the basis of all health care.
Yeah.
So why is it not heavily priority? Maybe it's a money thing. Is it a money thing? They're like, if you want to know in all these issues, come back. Yeah.
Yeah, we kind of have this perverse incentive in healthcare in the United States. It is a sick care system. And so from a financial standpoint, people make money when people are sick. For far and away, there are certain healthcare systems like Kaiser or health maintenance organizations where the payment structure incentivizes the healthcare system to keep people healthy because you're only getting paid so much to take care of a patient in one fiscal year. But otherwise, if you're more of a traditional care provider and you have people who are privately or publicly insured, you get paid based off of how many services you're delivering. And for the far and away, for the most part, counseling on sleep, nutrition, physical activity isn't really reimbursed. So that's another disincentive for providers to sort of sit and spend time. So if I sit and spend time and I see less patients, I make less money / my healthcare system. Anyway, we don't have to dive all the way into healthcare financing, but a lot of times physicians are sort of measured on how many billing items they generate, right? So in order to just meet their job requirements that they are contracted for, they're trying to optimize how many billable units of care they're doing. So it's a crazy system. All in all. And yeah, I think it's not rocket science, right? It's you're of course, all of these things. When you read it, you're yeah. And, somebody coined a term and now there's a college and whatever.
Yeah.
Which sometimes,
Yeah.
like, I'm like, we're just telling people, like, what grandma's told everybody for, like, so long, right? Like, this is grandma care. It's everything your grandma told you to do. And, you know, sometimes we're good at listening, sometimes we're not. No, I'm just kidding. There's a lot more to it than that. But, yeah.
Yeah,
It's interesting.
definitely. Oh, did someone say something in the
Eat your
chat?
veggies. That's right, Day.
It was me, sorry.
Okay, great. Before we move on, if anyone had any last minute thoughts regarding this slide that they wanted to share.
I like the blue zone. Like you said, me and my cousin yesterday were just talking about how we were gonna have to flee the country if that president of ours actually is trying for a third term. So I just sent her the link and I was like, I found our
Blue zone.
locations. I just found where we need to live. I said, go ahead and find some land for us to purchase
Here's the
to each
solution,
other.
blue zones.
I was like,
Yeah.
because this is not looking cute over here.
It's looking rough. Yeah, no, I actually just saw something similar where it was like if you're a stressed Gen Z or early professional, we'll pay you to take your mental health seriously. Come to us. We have like this whole retreat. You can live here. We feed you. All you have to do is chill out. And it sounded like a really good deal, I'm not gonna lie. I was like, okay, cool. Um, but yes, okay. So we wanted to finish up talking about your current research with the centering pregnancy model, which you and Dejanay fortunately are working on together. So we just wanted to hear you describe a little bit more about what the model is, what your role is in implementing the model. And yeah.
Yeah. So centering, maybe I can put a link into. So centering pregnancy is sort of a branded, if you will, model of care through the Centering Healthcare Institute. And so a group of brilliant individuals, see if that works. A group of brilliant individuals came together and said, you know, the way that we traditionally deliver healthcare in the United States, right? It's a one-on-one sort of patient provider visit. And one, are we missing opportunities for people to learn from others who are experiencing the same things that they're going through in terms of their health by not grouping them together and receiving certain parts of their care in sort of a shared setting? Like, what are we missing by not doing that in terms of social connection, in terms of sharing what works and what doesn't work, et cetera, et cetera? And two, from a provider perspective, like, you know, it seems like there's benefit to being able to provide group care in the sense you can see multiple patients at the same time, but also it creates more space for providers to sort of bond with their patients and talk with their patients than the traditional care model. And so they created what's called a centering model, and they, I think, started with pregnancy. They also have a centering pediatrics care model, which is for well child care. So they sort of bundle parents of kids who are the same age together for their well child checkups, which you go to a lot of those in the first couple of years. And so the centering pregnancy model is really beautiful. It starts ideally at the sort of the end of the first trimester into the beginning of the second trimester, where people are sort of I don't want to say in the clear because you're never really in the clear per se, but for people who have sort of crossed that 12-week sort of mark that people usually hold true in terms of, from a statistical standpoint, the pregnancy being viable and are now entering their second trimester, and they're going to embark sort of on more frequent prenatal care. And so the goal is to enroll people sort of after they get their first ultrasound. They're starting to enter their second trimester, and they join a group of expectant individuals who are in the same sort of stage of pregnancy that they are. And the groups could be anywhere from, you know, maybe 5 to 10 or 12 pregnant people. Different healthcare systems staff these group visits in different ways. And so, you know, again, I think this is part of the beauty of it. It's sort of like an infrastructure that people can then implement in the way that feels right for their system, or based off the resources they have, or based off the needs of their patients. At UCLA, our centering pregnancy model is based on a shared visit model with midwives and OB-GYNs. So every centering pregnancy visit is staffed by one OB-GYN and one midwife, which I think is really unique too. Usually you're sort of maybe seeing one or the other, or if you're seeing both, maybe you're a very high risk pregnancy and you want to see your midwife for most of your care, but you need to go to the OB for the high risk portions of monitoring your pregnancy. They tend to exist in separate silos. And this is actually like an interesting space where both of them are together. And the group meets 10 times for individuals who carry out a full-term pregnancy to 40 weeks. And each session is sort of broken down into some distinct parts. So the sessions are 2 hours long, which is very different from a standard prenatal care visit where you're maybe getting like, I don't know, 10 minutes-ish maybe with your OB-GYN if you're doing like standard OB care. So these are 2-hour-long visits. They start with individuals. So all the expectant moms are taught how to take their own vitals. So they take their own blood pressure and they weigh themselves. So it tries to teach people and give them agency over being sort of like stewards of their own health and monitoring their health. They document it, and then everyone sort of gets a chance to see the provider, right? So check in with the provider and they can do measurements and talk about anything that they need to. And while others are waiting to see the provider, there's usually snacks and it's like in a beautiful room and they can hang out and chit chat about whatever they want. And then there's sort of a agenda for discussion for the day for like a deeper dive based off of oftentimes where people are at in pregnancy. And in our model, frequently a guest speaker. So, we'll have like a lactation focused session. So after everyone checks in and talks about everything, they'll talk about, what do you know about breastfeeding? It's very conversational. It is patient led. So patients bring up what they've heard, what questions they have, they discuss them. And the midwife and the physician tend to be more of like they're a part of the group having the conversation. The hierarchy, I will say, of like a usual sort of doctor-patient visit is sort of struck down. Everyone's sitting in a circle and is part of the conversation. And so it's just like a really beautiful sort of interesting space to be in. And they cover all sorts of things that you oftentimes don't really get a chance to cover in your prenatal care. And besides that, I think at UCLA, we have a Centering Black Pregnancy group. And so that offers culturally concordant care. So that's led by Dr. Lisa Nicholas, who's a Black OB-GYN, and then Nkechi Brody, who's a Black midwife. And we try to prioritize guest speakers who are coming in who also identify as Black. And you can imagine there's like a lot of power and safety in feeling that kind of care and space and openness to having conversations that otherwise, people may not feel like they would want to have or could have with their OB-GYN provider in sort of a typical space. And it's really just sort of a wonderful thing. There's been talk about how to sort of scale that in terms of culturally concordant centering group models, thinking about different ways, different communities, right, that might benefit from having a culturally concordant model of care, especially in LA County. We have a very big Hispanic or Latinx population. So I know, or AAPI or Native Hawaiian and Pacific Islander, right? You could think of all sorts of groups for whom this creates a village in a sort of a vacuum where a lot of people don't necessarily have that same community that people once had when they were pregnant and giving birth, right? In terms of living by family or having close friends nearby who are going to come and help you all the time, or who you're talking about being pregnant with, right? We don't have that per se anymore. And so this creates like a space for people to find that, especially in LA, which is like money, because it's like so hard to find community in LA, which sounds crazy. There's so many people here, but at least that's been my experience, right? So I think I think the centering model, and I didn't do centering, so like I can't speak to it. This is like me sort of watching it, witnessing it. I've joined as a pediatrician in some sessions to talk about like picking the pediatrician and stuff. But I think in this part, in one word, what's the biggest benefit is that you feel like there's like a home where people feel understood. I think people feel cared for. I also think it's a home where people feel like they can say whatever they want to say, which is great, right? Like usually, people, it's like being at home with your family. It's like you might say things around your family that you would not say around other people, right? But it creates a safe space to have those conversations or to ask the question that if you weren't with another group of moms or expectant people, getting ready to give birth, if it was just you and the doctor, maybe you'd be like, oh, I don't want to ask that question because that feels like a stupid question or whatever, people feel. So I think it's that home piece. And I think it's also beautiful in the sense that it creates a community that carries through after the pregnancy too. So we've seen like a lot of the moms, there's a reunion after people give birth. They all bring their babies and, celebrate and all of that. And anecdotally, a lot of the moms, then that's like they're part of at least one of their like mom groups and networks, right? You've created an additional community now for their child too, right? So it goes beyond sort of just their prenatal care. And now I feel like I'm rambling, so I'll stop rambling for a second.
No, no, that was great. That was very informative. I was gonna actually ask before you had answered whether or not the group continues with like reaching out and outreach after everyone's given birth. Because I know obviously, with postpartum depression and the baby blues and all of that, like that's really when you do need that additional
Yeah.
support. And a lot of times, even if you are surrounded by family, like you don't know how I'm feeling after I just gave birth. I just popped out a human being. Like, what could you possibly say to me to make me feel
Yeah.
better? So I definitely think having that, I guess, longevity of support in that village continue even through or after you give birth is very important. I was gonna ask because I know doulas and midwives aren't interchangeable in terms of what they do, but is
Correct.
there an opportunity for doulas to be integrated into the centering model?
Yeah, absolutely. I mean, I think in its current iteration, um, the Centering Pregnancy group provides education on what doulas are and how to access them in LA County. I don't, I could be wrong. I don't know that there is a specific session where a doula comes in and talks about what doulas do, like from the mouth of a doula. Unless I don't know if Nkechi was a doula before she was a midwife. I'm not sure. But anyway, but I think that's a really important and exceptional question, right? And their Medi-Cal in the state of California expanded reimbursement metrics so doulas can be integrated into prenatal OB-GYN care, yeah, in a way that they haven't been able to previously. That being said, the rollout has been a little bit messy as it always is. But it's a great step, right, from a policy perspective in terms of trying to make this important service viable for people to actually access. Uh, and so we are working actually right now on not within centering pregnancy, but we're working with Charles Drew to do a doula education session for not for the moms in this first phase, but for the workforce about what doulas do and how to integrate them into care. Because I will let you in on a secret. A lot of doctors, if not most, don't understand the difference between a doula and a midwife. And I will say that they're not good historically at integrating them into care, like within delivery rooms, right? And that happens actually a lot, and a lot more because more people are using doulas. Um, and there's also like a whole lot of issues about access and who gets access and how they get access. And we don't have to dive into that. But I think that's a really great point, Amaya, and I'll bring it up with our partners because I love that. Yeah, they're such like a critical part of the workforce. And I think we've had discussions about too, particularly in that postpartum period, how they could be such a rich resource in a way that oftentimes the medical system isn't sort of like structured to be that way, if that makes sense.
No, that makes a lot of sense. Because right now I'm doing a fellowship with the Pennsylvania Department of Health with the Maternal
Hmm.
Mortality Review Committee. And
Yeah.
aside from like homicide and suicide and things like that, another big reason is just not having mental health support. And a lot of women go
Yeah.
into their pregnancy already with like a mental health condition, depression, anxiety, things of that nature. And it just throughout, they just don't have the support. Like obviously when you go to the doctor, how are you doing? Da da da, and they do your 6 week postpartum checkup. But after that, it's like, okay, now I feel more isolated. I feel like I'm on my own. I don't really have like someone who is, you know, as a crutch essentially
Yeah.
throughout this period, which is probably one of the most vital times after you're pregnant. Um,
Yeah.
so yeah, yeah. But for the chat, well, for the girlies, everybody here, we just wanted to get some more um, thoughts about if you could, in one word, what is the biggest benefit to having community during pregnancy? So you can either unmute yourself or add it in the chat. But just before we wrap this up, we just wanted to give another option to get some opinions. Okay, great. Support, yes. Security, yes. I wasn't thinking of that one. That was a good one, Naya. Joy, laughter. Oh, yeah. It doesn't always have to be something like a way to intervene or something. It can just be a way for you to still find yourself, even though you're a new mom or a new parent. That's really good. That's so cute. Okay, great. Alrighty. Well, we are going to go ahead and move into our Q&A portion. I didn't see any in the actual Q&A section, so if anyone has any last minute questions before we wrap up regarding anything that Dr. Gragnani had said, or just any questions in relation to her background in public health as well, now is a great time.
I'm an open book.
I think the thing is, you were like so thorough. They're probably like, I have
Yeah,
no questions. Like, you
that's
answered
totally
every
fine
single thing
too.
I would have asked.
Yeah, no pressure.
Okay,
Um,
cool.
yeah, no pressure at all. And or if, questions come up after, that's fine too. Or if you have questions about just like making life decisions and you want an old person to talk to, I'm also here for that. Um, hopefully I have a lot more decisions to make, but I've also had to make a lot. So, I can share my experiences there, both good and bad.
Yay,
Ooh,
a
really good.
hand.
Go ahead.
Hello, hi. Hi.
Hi.
You gasped really loud, so I was like, I kind of scared.
Sorry, Cynthia came on and she was I'll still consider you my mentee. Anyway, I was surprised, but I'm also very excited for your question, but I hope I didn't scare you.
No, I've taken your. I'm gonna turn on my camera, but I've taken your class for like
Oh
a very small amount of time at
yeah.
UCLA. So I'm like, did she just recognize me by my voice? I was like, oh hi. Yeah, I took your class, your undergrad class, like for a very
Yes.
short amount of time, and then I
Yeah.
had to, yeah,
You
I
had to
had
drop
to
it.
leave. Yeah, I had to drop. Yeah, this was literally last year, but
Yes, I
and
remember.
I follow MC. I'm an undergrad. You guys were all grad students. I was like, wow, they're all so amazing. I'm an undergrad. I followed the Instagram and then I saw Dr. Gragnani and I was like, oh my God, like I'd love to see her talk again. But you guys are all doing amazing work. That like PhDs and undergrads, that's amazing. Um, but I had a question about wondering how some of like these community-based resources that um you're trying to like create or I guess like include in like this like I really like how you're including in like it's like longer sessions with patients. I feel like that's like it's like something unique that I haven't really seen before. I know with like
Yeah.
Kaiser, they do kind of offer something like that, but I like how this is like their regular visits, because they do get to have that one-on-one with the provider as well. Is there like a way that and you said you're working with like it's like working with UCLA Health, or is it like it's
Mhm.
working within UCLA? Is there
Yeah,
like
centering is at UCLA. This centering, they're centering in all sorts of places, but the one I'm talking about is at UCLA.
okay, cool. Yeah. Is there like any version of that that kind of works on like the regular I guess the regular doctor visits that you guys have tried, or yeah, that's like not like that longer portion, but still like has like the doctors kind of incorporated into like there's still like interaction with the patients.
Yeah, so we have done outside of pregnancy care from a preventive medicine standpoint, our group I haven't done it for quite some time, but Dr. Priyanka Fernandez is still running this with our preventive medicine training program, but we have offered group lifestyle medicine visits.
Mm,
And so that is sort of regardless of whether or not you have a diagnosis of a chronic disease. It's typically adult centered and focused. We've tried to outreach to the pediatrics group to see if we could do group lifestyle medicine visits for kids, but that sort of hasn't panned out. Pediatrics is also very underfunded as a healthcare space, so it's even
mm,
harder to sell people on decreasing revenue even more, because it actually when you get into bigger healthcare systems, oftentimes relies on the revenue streams of adult medicine to be sustained.
mm.
So it's another little, I know, crazy part about pediatrics. But we've done group lifestyle medicine visits with variable success. Loma Linda
Mhm,
does
mhm.
they have a very robust lifestyle medicine program. And I would say that they're sort of like on the leading
That's why they're
edge
the
of,
blue zone.
yeah, yeah. Yeah, so they're based in the blue zone, which definitely helps. And they're sort of on the leading edge of a lot of lifestyle medicine research. And they've done a lot of interesting things in terms of trying to figure out how to build billing and things so that it is financially feasible for the healthcare system to actually offer care in this sort of a way. So there are other examples. And then some individual providers create group spaces for their visits. So there's another primary care doc, for example, at UCLA, her name's Elizabeth Coe, and she does
Mhm,
like, once a month on, I don't know what it is, right? But like
mhm.
on third Thursday of the month or whatever, from 5 to 6:30, she does like an educational session on diabetes, like pre-diabetes
Mm.
prevention. So like
Oh,
she has
cool.
created that space in her own clinic where for her once a month is feasible to just take an hour and a half or 2 hours and talk with patients in a way that she otherwise doesn't get to, right? And she
Mhm.
actually, I mean, I've only witnessed it once. I went and saw it once, but there was probably a good 20 patients there, which is a lot, right?
Yeah,
Like
that's awesome. Yeah,
20 patients were
honestly,
like,
I feel
yeah,
like
I want to do this.
yeah, I feel like it's like maybe the assumption is like a 2 hour visit is like people don't have enough time for that, but
Yeah.
it I mean, it's not like how often are the 2 hour visits? It's not that it's like very often, right?
Yeah, the for centering pregnancy, it can become more of like a potential barrier in terms of like depending on the opportunity cost for people who work, et cetera, et cetera. And so that being said, they are able to sort of understand for the whole course of their pregnancy when their visits are scheduled, because it's like a set schedule.
Oh, nice.
And so
Yeah.
that's to try and help people to be able to maneuver at work with like scheduling and things. The other part about centering that I actually didn't bring up that's also important is that they can bring like their partner or like their a support person with them to their
Oh,
centering visit. So sometimes dads
yeah.
come, sometimes it's like a bestie, sometimes it's whoever, but it also creates like a nice space for them to be part of the conversation. And also I think to that safety and security piece and the laughter part too, it makes people feel more comfortable like sharing, because like their partner's here to back them up with whatever they're saying or whatever question, or you just make them ask the question for you.
Okay, thank you so much. Thank
Yeah,
you.
of course.
Does anyone have any additional? Oh, go ahead.
I didn't have a question. I just like want to thank you, Dr. Gragnani. I feel like I always learn something. from you every time I hear hear your talks. So I'm just grateful. I like miss seeing you like every
I miss
week.
seeing you too. I sent you a DM. I was like, you're alive. I'm so glad. Chicago's so cold. We miss you
Barely.
here in
We had like
California.
fake spring last week and now it's like
No,
cold again.
that'll get you. That will get you every time. It is a lie.
I walked out with no heat tech the other day and I was like, oh, I got a little too overconfident with the fake spring. But yeah,
Oh my gosh. Well, thanks for
great
joining
to
us.
see
It was
you.
good to see you. Yeah, me too. It's great to see
No,
all of you.
shout
Great to
out
meet new
Cynthia.
people.
And I miss my girl Maya.
Miss you. Yeah, sorry
Dejanay.
everyone. This is like a fake reunion.
Yes.
Cynthia was our previous research co-chair as well, our previous research and practice coordinator. So we miss her, but we love Dejanay. We're all just one happy little girl gang family. So well, let's move on.
Best place to
Right.
be.
I'm like, I'm just happy to be here.
Yeah.
So thank you guys so much. We really appreciate everyone attending and taking the time to discuss. If you would like to connect with any of us, our LinkedIn as well as Dr. Gragnani's email is here as well. And if you do have any additional questions, like she said in the beginning, please feel free to reach out. And I'll also send this in a follow-up email with her information and the links that she provided as well. In regards to the Maternal and Child Health Network, we do have a lot of upcoming events planned for you. So you can always follow our Instagram or visit our link tree for any additional updates regarding upcoming programs and live events. Also, please feel free to subscribe to our newsletter if you haven't already to get the most updated information. And if you could kindly, we do really want to hear your feedback on our coffee chat. So please feel free to scan the QR code and I'll also drop the link in the chat for our end of chat survey. I'll also send that in the email though. So thank you guys so much. If anyone has any last minute thoughts, questions, concerns, feel free now. But otherwise, please enjoy the rest of your night. And we really do appreciate you guys for tuning in. Oh, what's going on in the chat?
They're blowing up the chat, girl. Thank you, Kendi. Thank you all so
Yeah, of
much.
course.
This was such a wonderful conversation. Oh my
Thanks,
goodness.
everyone. Yes, I know. Big props to Day and Amaya.
Oh, thanks, guys.
Thank you